I would like to invite Dr. Sagar to present on cataract surgery in post-refractive surgery patients.
Good morning, everybody. At the outset, I'd like to thank Dr. Mona for this opportunity. So I will be speaking on cataract in post-refractive surgery patient. As we all know, a post-refractive surgery patient coming for cataract is always a challenge in terms of how to do an IOL calculation for the patient, what type of lens to implant, and sometimes difficult scenarios in during the surgery. So we'll cover these aspects. So we'll cover these aspects during my talk in brief. So whenever a patient comes to you with a history of undergoing refractive surgery, it's very important to look at the pre-refractive surgery refraction and the vision of the patient. That will tell us whether the patient was having indeed any amblyopia. Once the patient has undergone post-refractive surgery, check the spectacle cylinder and the axis and the best corrective visual acuity, because that will tell us the quality of vision that the patient was enjoying. And of course, if the patient is on contact lens, we need to discontinue lenses for at least 1 to 2 weeks, depending on the lens that the patient is using, so that we get the correct biometric values. Clinical examination is important. Ocular surface has to be evaluated very thoroughly. Any evidence of dry eye should be treated beforehand, because we all know that dry eye will lead to poor K estimation and eventually poor IOL power measurement. So this has to be optimized perfectly before doing any measurements. So investigations would basically mean the patient should undergo an optical biometry. That's preferred because all these formulas have been standardized for optical biometry. Topography is must for any patient who has undergone a refractive surgery, and sometimes you would need special investigations like aberrometry, and we'll see why. So optical biometry, most of the current generation optical biometers have post-refractive surgery mode. So make sure that is activated before doing the measurements. And in patients who have undergone RK, we all know that there is a diurnal variation in the corneal curvature in these patients. Being flattest in the morning, that's when we would like to take the measurements, so that we get the maximum possible IOL power. So do we need to repeat it in another biometer is another question which gets frequently asked. So yes, you should do it if you are planning for a toric IOL, and Dr. Douglas Koch actually came up with this nice guideline which tells us that how do you actually decide which patients you should do toric IOL. So this is a simple guideline which says that the patient should have regular bow tie corneal astigmatism within 3 millimeter zone. The difference between the two optical biometers in terms of the corneal astigmatism magnitude should be below 0.75, and the difference of astigmatic meridian should be less than 15 degrees. Let's see an example. See, this patient had measurements from IOL Master 700 and Lenstar, and you can see that the axis difference here is 13 degrees and the magnitude difference is only 0.54. So this is an ideal patient where you can take up for toric IOL. But you see this topographic map of this patient. So not every post-RK or post-LASIK will have a regular bow tie astigmatism. There will be really some element of irregular astigmatism here, and in a very extremely flat cornea, it's difficult to pick up bow tie. But what you can do is you check the spectacle astigmatism of this patient from the old record, and this was consistently the reading, and the patient was actually indeed reading 6/9 before the cataract formation. So we went ahead and did the surgery for this patient and had a good outcome. So what is the role of topography? So topography is very important in these patients because of these things. We'll come to them one by one. So basically it will tell you what is the ablation in that particular patient. We all know that if there's a decentered ablation, there is a chance that the patient will have increase in higher order aberration, especially coma, which would mean that the patient will have poor visual acuity post cataract surgery. So this has to be warned to the patient beforehand. Again, the IOL power calculation may not be that accurate in these patients. Even if you have a centered ablation, you look for the regularity of the ablation, and this is possible in Pentacam when you actually look into the holiday report in Pentacam, where you can actually see the corneal power distribution curve in the zone that you need to measure. And if you get a regular, if the surface is regular, you'll get maybe a 1 or a 2 peak max to max and a nice plateau. But if you have an irregular surface, as you can see here, you can see multiple peaks. So here is the chance where you might get actually a refractive surprise, because you never know which points are being measured for the IOL power calculation in these cases. Now, the topography gives us input for the ASCRS calculator also. So like ISIS, Atlas, then you have OCT and you have Pentacam. Especially in Pentacam, you get this value, that is TNP apex at 4 millimeters, which is used for elastic calculation, and PWRSF people, which is used for RK calculations. So you can get that input from that, and this is the power distribution map from where you get this input. Now, a very useful display is pre-cataract, pre-op cataract display, which gives you these two values, which is corneal higher order aberration and corneal Z40 or Z40, which is basically spherical aberration. So any patient who shows higher increase in total higher order aberrations more than 0.3, 0.5, you are basically looking at higher irregular astigmatism, and these are the patients who are not really fit for EDOFs and trifocal lenses. And of course, corneal asphericity we'll just understand with this slide. So when the next question comes is that most of our lenses are aspheric or non-aspheric. What would you decide? What would you put? So if you have a myopic LASIK, we all know that you will have higher positive spherical aberration. So in these cases, you can put an aspheric IOL which has a negative spherical aberration, which will basically reduce the spherical aberration. And in hyperopic LASIK, to start with, it has a negative spherical aberration, so you would not want to put an aspheric IOL, but an aspherical IOL or an aspheric aberration-free IOL can be implanted in these patients. Sometimes you need additional investigation. This was a patient who had a LASIK about 15 years back, had a regression, and was complaining in the right eye, glare and halos. But in last 1 year, he further had decrease in the vision. On slit lamp examination, he had earlier nuclear sclerosis. You see the right eye map, the left eye map, both show the slight decentered ablation. Now, what the dilemma is, what is causing the decreased vision? Which component is more? So if you look at the left eye, so in these cases, eye trace helps. So you can see the left eye, all the aberration values are well within the normal range. So the left eye per se, the quality of vision is quite okay. This is how the E looks in left eye, but you see the right eye. Now you see the lens-based aberrations are also there, as well as the corneal-based aberrations are there. So that means the patient will have poor visual acuity in both those things. So this is the lens-related the aberration, this is the cornea-related aberration. So even if you do a cataract surgery in this patient, the cornea is irregular, you will have poor quality of vision. In such cases, probably you would do a corneal treatment first, regularize the cornea, and then do the cataract surgery. EDOFs and trifocals in a post-refractive surgery. So we have to ensure that the patient had good quality of vision, especially night before the onset of cataract, if you're considering these lenses. Post-hyperopic LASIKs should completely avoid putting these lenses. We have to check that the ablation is central, higher order aberration is below 0.5, and any coma or trefoil in their absolute value should be below 0.3. IOL power is another big topic, but conventional biometry fails because of multiple errors. I'll not go into details. And as a result of that, we have close to 30 plus formulas. Luckily, we have ACRS calculator, which has actually checked and ratified few formulas in their website. And now you also have inbuilt formulas in different biometric machines, as you can see in the list out here. So in ACRS calculator, if you go through, you can have to basically fill up all these proformas depending on the data that is available. So if you have a pre-LASIK data, you can fill up all this data, post-LASIK data, and then of course biometric data. And this he'll calculate. One important point to remember is if you are inputting refraction, the cylindrical value, even if it is 0, has to be inputted as 0, otherwise you will not get the value. So these are the formulas which are available on the ACRS website where the pre-op data is not available, and when the data is, when there is no data which is available. So in general, the methods which does not rely on data works better. And of late, now we are basically looking at certain other methods which are helping in better IOL power calculation. In this total cataract from IOL Master 700, which basically incorporates both the anterior and posterior corneal curvature and combines it with the inbuilt Barrett True K, is showing results. So this is the same patient showing 19.5 and 20 when you check with TK and K. And now the formulas which basically combine TK with Barrett or EVO or Haggis are showing slightly better performance than just plain K value or Barrett True K. So So that is one thing to keep in mind. Artificial intelligence has come in cataract surgery, and in this you have in post-LASIK you have only one AI formula which is available online, that is Pearl DGS. Just to show an example, this is a patient where we did a post LASIK. This Pearl DGS is showing us a 0.7 when we decided to put a 7 diopter lens, and Barrett True K was showing 0.14. So we went ahead with the 7 diopter and we got a post-op spherical equivalent of 0.35. So these formulas do work. RK, Dr. Bhaskar will be covering, but just in very brief, generally you need to target RK patients a little myopic depending on the number of cuts that they have. This is just a last case which I just want to show. This was a patient with an axial length of 35 millimeters, and the A-series calculator gave us the value of around -5 to -7. So we took the maximum value of -5 diopter sensor, which we decided, and this was the small video which I'll just show you the video. It's a 40-second video. So you see the level of difficulty that one has in dealing with such cases. You have a huge central scar. This is a one-eyed patient, other eye lost because of RD. Usually in these cases we don't do a clear corneal incision. A scleral incision is always preferable, and these incisions will open up. So depending on the number of incisions that open up, we obviously have to take the sutures. CTR was used because it was a large bag and we wanted to stabilize the lens. And finally, the 3-piece lens is being implanted, and you can see one more incision opening up, which was duly sutured. There was a third incision which opened. Ultimately, the patient did well, got an ambulatory vision of 2/60, and in the post-RK patients expect hyperopia initially, and there will be a myopic shift and eventually stability in next 3 to 6 months. So I would sum up by saying that post-refractive cataract surgery needs more detailed evaluation. Methods for IOL power calculation are becoming better. Definitely, we are able to predict better now. Choice of IOL would depend on multiple factors, and surgical steps in RK will need modification. Thank you so much.